Good morning, and welcome to the plenary session and opening of the Section's November 2020 special meeting. My name is Russ Kreidel, and I serve as chair of the AMA's Board of Trustees. It's my honor to be with you today to guide you through our plenary session. 2020 has tested us in ways few of us could ever have imagined. And I want to extend my thanks to all of you on behalf of the AMA Board for all you have done during this incredibly difficult time, caring for patients, exposing yourselves and your families to a deadly virus, and keeping your practices afloat. This year, more than at any time in recent memory, physicians have needed an ally on their side. And I'm proud to say the AMA has been there from the very beginning of this pandemic. That's a credit to you and to other physician leaders everywhere who have stood with us. I thank you for your commitment to patients and to physicians and for being a part of these virtual section meetings today. As you know, this meeting was originally scheduled to take place in San Diego, where we met last year at the same time. But the world has been turned upside down in the course of this year, which we'll discuss in today's plenary session. We have a dynamic virtual program planned for you, and that will focus on how the AMA has risen to the challenges and also on how we plan to meet the challenges of the year ahead. And so I thank you for your attendance and your participation. It's now my great pleasure to introduce our AMA President, Dr. Susan Bailey, for some opening comments. Dr. Bailey, please proceed.
Thank you, Dr. Kreidel, and thank you for your strong leadership of our organization in this historic time for medicine. Good morning, everyone, and thank you for the opportunity to join this historic section plenary session today. It goes without saying how much I wish we were together in person and how I look forward to the days when we can meet together. I want to start with a special thank you to the members of our 11 sections. Now, because there are people joining us today who might not be familiar with all of our sections, I'd like to list them all so you can appreciate the diverse representation of backgrounds, of ideas, and experiences that make up our sections. First, we have a medical student section, and I am actually proud to say that I am celebrating my 40th year as chair of the MSS. We have a resident and fellow section. We have a young physicians section, a women physicians section. I chaired its great-great-grandmother, the advisory panel on women in medicine back in the day. We have a minority affairs section, an advisory committee on LGBTQ issues, an international medical graduate section, an academic physicians section, an organized medical staff section, an integrated physician practice section, and a senior physicians section. I'm almost there, but not quite. And I hope that there are going to be more sections to come in the very near future. Now, as you can see, our sections encompass physicians of all stripes, of every age, ethnicity, sex, and gender orientation, from every practice setting and every specialty, physicians from U.S. medical schools and around the world, physicians representing every state and U.S. territory. I'd like to join Dr. Kreidel to thank each of you for staying active in supporting the AMA and physicians everywhere in this most challenging year. I want you to know how much your Board of Trustees truly appreciates your work and your dedication to our AMA. I want to say a few words about how, with your help, our AMA is uniquely positioned to represent physicians with a unified voice. I imagine most of us here support our state and local medical societies, as well as our specialty societies. And of course, we should support them because they speak to important issues close to home or that are specific to our specialties. But when we come together at these meetings, we are representing all physicians, all specialties, all practice settings, and all regions of this great country. There is no other organization in our profession that can do that. As past Speaker of the House of Delegates, I can assure you that reaching a unified voice at these meetings can often be a very difficult process. Many say it's like herding cats. but that speaks to the complexities of the issues in medicine today and the challenges we confront as leaders of our profession. The process for developing AMA policy, a process that you are all about to embark upon at your section meetings, is a time-honored tradition at the AMA. In the end, the policies and positions that result from these meetings unquestionably impact the work of our AMA. They are our marching orders. Now, while it's not always quick or easy, it is an amazingly democratic process, one where all voices are heard. So thank you for the work that you do to assure that our AMA speaks with a unified voice for all physicians, medical students, and the patients we serve. Now let me shift gears a bit and highlight some of the work of the AMA in response to the COVID-19 pandemic. There is no way to overstate the profound impact COVID-19 has had on our nation's health, on our health system, on our economy, and on our overall way of life. The physical and emotional toll of this pandemic has touched all of us, families in every community and every state. Physicians, medical students, nurses, and everyone on the front lines of this pandemic response have courageously risen to the challenge. Some have died. Many have fallen ill. All have worked extremely long hours and sometimes dangerous conditions. In confronting one of the greatest threats to public health in our lifetime, the AMA has worked aggressively to meet the urgent needs of physicians by advocating for the resources, the protective equipment and supplies that you need, by providing trusted, evidence-based information, and by fast-tracking the tools and resources to help you and your practices recover from this sustained disruption. Some of these things include developing comprehensive online resources from a variety of trusted evidence-based sources, including the JAMA Network COVID-19 Resource Center, which has an incredible overview of COVID-19 related topics, from epidemiology to infection control and prevention recommendations, all available for free on its JN Learning website. Our AMA COVID-19 Resource Center and Physician's Guide, which are also available for free on our website, provides perspectives rooted in science from AMA's physician leaders and subject matter experts, including tips on how healthcare facilities can manage PPE, on how to establish effective staff safety protocols, on advice to give patients, and on dispelling common myths about COVID-19. AMA continues to push the administration to use every lever available to them, including the Defense Production Act, to solve production and distribution challenges for COVID-19 testing and protective equipment, to ensure that physicians can do their jobs while minimizing their personal risks of exposure. As the AMA urges the federal government to rectify this PPE shortage, we have also taken action to provide some immediate support for AMA members by collaborating with Project N95, a not-for-profit national clearinghouse for PPE, to arrange exclusive access to purchase quality certified PPE with no minimum amounts. This program has allowed AMA members, particularly those in small and independent practices like mine, access to N95 respirators and disposable isolation gowns without having to order 10,000 at a time. In our first campaign, we distributed more than 258,000 units of PPE. Coming soon on November 10th, next week, we'll provide another exclusive opportunity for AMA members to purchase the quality certified PPE they need. Be sure to follow AMA on Facebook or Twitter for the announcement so that you don't miss this limited time offer. We combined forces with the American Hospital Association and the American Nursing Association to successfully push Congress to pass legislation providing more than $100 billion to support frontline healthcare personnel, as well as loans for up to $10 million through the Small Business Administration to help physicians in private practice cover payroll and overhead costs with expanded loan forgiveness criteria. We supported congressional action to advance payment parity of telemedicine. AMA supports the Healthcare at Home Act to ensure telehealth coverage for normally covered benefits, including mental health and substance abuse treatment during the pandemic. We created resource guides for medical students and residents to navigate complex issues around COVID-19, and also for senior and retired physicians who may consider providing their services to the pandemic response efforts. We successfully urged the U.S. State Department and the Department of Homeland Security to fill critical gaps in our COVID-19 response by leveraging the experience and expertise of international medical graduates, as well as physicians, medical students, and residents who depend on the Deferred Action for Childhood Arrivals, or DACA program, for their eligibility to study and practice medicine in the United States. We advocated for added liability protections for physicians in federal legislation and state executive orders to provide safe harbors for physicians when faced with suboptimal treatment arrangements, patient surges, and postponement of elected procedures. Now, all eyes are on the rapid development of a COVID-19 vaccine to try to restore some sense of normalcy to our lives. Excuse me. Normal vaccine development timelines are being compressed, and public-private partnerships have been formed to provide funding, but the need for safety and efficacy must remain our top priorities. I know you will hear more about the vaccine development process next with Dr. Fauci, and you'll hear more about the work of the AMA to plan for what's expected to be a very difficult year ahead. The painful lessons from this pandemic will be etched in our minds for a very long time. We must do everything we can as physician leaders, and by leveraging the power of our collective voice through organized medicine to bring an end to this crisis. We have learned a lot and made incredible progress in how we treat and care for patients with COVID-19, but we have a long way to go and much work still ahead of us. So let me close by saying, I hope you all will recognize that the work you are about to engage in, shaping policy to guide the AMA, is now more critical than ever. We need your expertise and we need your voice. So thank you again for being part of this special meeting. Now I'll turn it back over to you, Russ. Thank you.
Thank you so much, Dr. Bailey. You've been an incredible leader, and you've done tireless work on behalf of the AMA as a spokesperson with strength and fortitude, and been representing all physicians everywhere so well. Thank you so much. Now, for the next portion of our program, we are featuring an exclusive discussion with the AMA CEO and Executive Vice President, Dr. Jim Madara, and the esteemed Dr. Anthony Fauci, who directs the National Institute for Allergy and Infectious Disease and has a long and distinguished scientific career. You know, we first recognized Dr. Fauci's excellence when he was a young person in science with the AMA William Beaumont Award in 1989, and then again in 1992 with the AMA's Nathan Davis Award. And we continue to admire his huge contribution to science. I know I speak for all of us when I express our deep thanks to Dr. Fauci for keeping science at the forefront of his agency's work on the pandemic and throughout his entire career as a public servant. You know, during this pandemic, Dr. Fauci has been a guest on Dr. Howard Bachner's JAMA podcasts multiple times and has given generously of his time to the AMA in many ways. And we thank you, Dr. Fauci. You know, at a time when science itself has been undermined by a torrent of misinformation, disinformation from the highest levels of government and also in the press, Dr. Fauci has been steadfast in his dedication to science, evidence, and data to protect patients in this pandemic and to lead us through the pandemic. And for that, we all owe him a debt of gratitude and admiration and strong support. Welcome, Dr. Madara. Welcome, Dr. Fauci.
Well, welcome to the 2020 AMA section meetings. As always, we use this time to shape policy in the interest of the health of our patients. Now, obviously, the pandemic makes this time unique, so it's fitting that to get this kicked off, we have the privilege of interviewing Dr. Anthony Fauci, someone you know really well. Dr. Fauci, as you know, has served as director of the National Institute of Allergy and Infectious Disease since 1984 and has been an extraordinary public servant and also a scientific leader in the field for more than 4 decades. Most recently, he has been recognized for his deft, scientifically grounded leadership related to the COVID-19 pandemic. And simply put, he has been the reliable source of facts based on the best evidence at the time as this pandemic unfolded with surprising and sometimes nearly astounding twists and turns. He served similar leadership roles in the past during HIV, H1N1, and the challenges related to Ebola as well. So Dr. Fauci, thank you very much for being here today and being such an effective voice for reason and science in this difficult time. The topic today is the year ahead, maybe it should be the 2 years ahead, and I'd like to begin with what's on the headlines today of the COVID-19 vaccines. And assuming that one or more of the vaccines are shown to be safe and effective, and a significant portion of the population is vaccinated, how do you see the next 1 or 2 years unfolding? And then part of that question also is I sense almost implicitly when you hear people speak, read media, that there's a sense that once a vaccine is out there, the door is closed and the pandemic's over, which doesn't sound too mathematically possible. So where do we stand and how should we be looking at this?
Well, I think the issue with vaccines is actually good news in a time of considerable concern and stress about the outbreak. We have 6 candidates that the United States government is helping out with, either in the development of or in the facilitation of the testing of. 5 of those 6 are already in phase 3 trial, and 2 of them, the Moderna and the Pfizer product, started phase 3 trials on July the 27th. They're fully enrolled, and as you and I are speaking right now, data are being collected regarding efficacy and safety. And we hope that as we get into November and maybe in the early December, we will get an answer as to whether or not one or more of these candidates are safe and effective. I'm cautiously optimistic that we will have a safe and effective vaccine, and then we'll be able to start distributing doses reasonably soon thereafter in a graded fashion to individuals with the highest priority, such as healthcare workers and people on the front lines. What that's going to mean, apropos of your question, is that there are 2 factors that are going to determine the degree to which public health measures are going to be playing an important part in protecting our country and the people in our country. First of all, how effective would the vaccine be? And as importantly, how many individuals are going to opt to take the vaccine? Because you know there is a considerable degree of reticence, skepticism about the vaccine that we need to overcome by transparency and messaging and reaching out to the community. But if we get a reasonably effective, 75% effective vaccine, and a substantial proportion of the population takes the vaccine, I think we're going to be going in the right direction towards approaching some degree of normality as we head into 2021 in the second, third, and fourth quarter of 2021. So that's good news. I mean, obviously you can't declare victory until you get the results of whether or not the vaccine is safe and effective. But as I mentioned, I'm cautiously optimistic based on data that we have from the animal studies as well as from the phase 1 trials showing a robust degree of neutralizing antibodies in those early phase 1 studies. So things are looking good in that regard.
You brought up the issue of safety and recognizing that some of the vaccines are new platforms, these mRNA vaccines. does it take any extra caution, or how do we think about safety in the context of a new platform?
Yeah, well, we're always focusing on safety, whether it's an old or a new platform, but you're absolutely correct. When you're dealing with a new platform like an mRNA, you want to stay heads up for maybe different types of adverse events that you're not used to seeing in other types of platforms. So you're absolutely correct. There's going to be a real sharp heads up to make sure that we don't miss any unanticipated severe adverse events. And if they're severe, it's very unlikely that you're going to miss them, but you want to make sure you keep your eye out on them.
Do we have any worries once a vaccine is approved and shown to be safe and effective, that people in other trials for other vaccines might leave those trials to get something that's approved? How do we think about that possibility? Is there something we should be doing around that?
Well, we're actually prepared for that eventuality, that you might see a vaccine that shows to be safe and effective in December, and then there's another trial that's not going to end until March. So what happens to those people in those trials? It's really going to depend on a couple of factors. A, how effective a vaccine is. Now, if a vaccine is shown to be 95% effective, then it's very likely that what you'd have to do, besides breaking the blind and giving it to the people who are in the placebo arm of that given trial, you might want to modify, and again, I say might because I don't want to get ahead of the people who are designing the trials, but one of the options would be to make the placebo arm in that second or third trial the actual vaccine that was just shown to be effective. So you could do a non-inferiority trial, which would require getting more people enrolled, but you could compare the unproven vaccine with the one that's proven. So if it's as good, well, then you'll know it's as good. It's 90% effective. If it isn't, well, you want to find out how much it isn't. If it's 85%, that's pretty good. If it's 40%, not so good.
This is maybe a bit of a theoretical question, but it's noted that, knowing that what we do about the biology of the virus, the spike protein seems to be something that one would go after. And if one were devising a vaccine toward a surface element, it would be hands down logical to go in that direction. So, every company you can imagine thinking that way. But when you think of the worldwide portfolio of vaccines, is it wise or not to have the vaccine dominated by one target?
The answer is no, but this target is so clearly important in the binding of the virus to its cellular receptor, which is the ACE2 receptor, that you would have to have the predominant effort being using the spike protein receptor binding domain as the target of the neutralizing antibody. But you're absolutely right. You never want to put all your eggs in one basket, and that's the reason why the next generation of vaccines certainly will include something above and beyond the receptor binding domain of the spike protein. But you would really have to go with that first and predominantly, from everything we know in animal studies and even in vitro physiology.
So one of the things you brought up was the pathway to herd immunity. And you mentioned, a vaccine, say, could be 75% effective, and I understand the floor for acceptance is around 50%, and you'd even hope for something better than 75. When one starts playing with numbers and you think that, maybe to get to herd immunity, you would have to have 70% of the population have an immune response, and so maybe 50 or 60 million Americans will have been infected by the virus. And you start playing with those numbers a bit, and it's kind of hard to get to the 230 million that would be 70% of the 330 when you start altering each of the variables. Is that a worry for us, or do we think that we're just going to have more infection in the population in maybe a slow way so the health system can deal with that? Or how should we be
Yeah,
thinking about that?
I would prefer to look at it in a more positive way. I understand where you're going, is to lessen the dependence on infection and heighten the dependence on vaccine. And the way, I mean, if you have a vaccine that's 78% effective, you can't make it any more than 78% effective. But what you can do is get more people vaccinated. So there's two parts of the equation. There's the efficacy of the vaccine itself, and then there's the number of people who take the vaccine. So what we need to do to really put a lot of the effort on the herd immunity that's vaccine induced, we need to just get a lot more people vaccinated.
The death rate now compared with the terrible months of March and April seems attenuated. To what part is that attributed, that we just know how to deal with this better versus testing, versus we're dealing with a more resilient population now getting infected? How do we put all those things together in understanding that lower death rate?
Well, it's all of the above. First of all, as we've learned with every disease that's new and that we've been challenged with, from HIV to other types of diseases, we just get better at treating people. More experience, you know what works, you know what doesn't work, including just fundamental non-pharmacological approaches. You know, whether to put people on ventilators or not, whether to make oxygen be much more prevalent than intubation. Those are the kind of things that we've learned. Number two, we have treatments now. We know that dexamethasone clearly diminishes the death rate in people requiring mechanical ventilation and or high flow oxygen. We have remdesivir for hospitalized patients who have lung involvement. And also, we're starting to see a younger population get infected. In fact, if you look at the age range for people getting infected now versus people who were getting infected in the spring, there's almost a decade difference of being younger now, mostly because college kids coming back to school, they're getting infected more. Ultimately, they're going to wind up affecting people in the community, but they're the ones that are sort of driving the infection. So it's age, experience, and better drugs.
And when we think of those drugs and the therapeutics that are coming out, it sounds like the dexamethasone is cheap, something we can take to the bank now. Remdesivir, it seems like you hear one thing from WHO, another thing in terms of the FDA approvals. How should we be thinking about that compound?
Well, it's not a knockout drug, for sure. I mean, it's a drug that has a beneficial effect in diminishing the time to recovery. But it isn't, a blockbuster in the sense of it really makes things dramatically different. But it does have a beneficial effect. You don't want to discount that, but you don't want it to expect it to do something that it's not doing.
And when we think of anticoagulant use, are they used in very specific subpopulations? And how do we think about that?
Well, usually with advanced patients who have beginning of organ system function, we're starting to do it prophylactically now. We're starting to see that, we know now for sure that it's the case, that there is a degree of hypercoagulability that's associated with advanced disease. You see that in curious microthrombi in small vessels of different organs, kidney, heart, even nervous system. But you also see more dramatic thromboembolic phenomenon, sometimes leading to strokes in otherwise relatively normal people. So there's no doubt that there's hypercoagulability, and either treatment or prophylaxis with a variety of anticoagulants is something that is now common practice with COVID-19.
There are some people that work with in the innate immunity of mucosal surfaces are wondering, what is the role of secretory IgA? That's such a big defense factor in, GI and airway, and don't hear much about it. Do we know much at all about the role of secretory IgA?
No, we don't know specifically with regard to COVID-19, but given the history and our knowledge over many, many years of secretory IgA, I cannot imagine that it doesn't play a role when you have a respiratory-borne illness that enters and resides in the upper airway and then goes to the lung, as well as the fact that you have a considerable degree of GI involvement in some individuals. So I can't imagine it's not playing a significant role.
So the sections that are meeting now are part of our House of Delegates, 180 medical societies, all state and specialty branches of military medicine. And the leadership of those societies are part of the recipients of this knowledge. And in medicine, as you know, in the last half century, we've moved from episodic to more chronic disease. And now with COVID, we find these very odd symptoms and effects in a longer period of time. So how should physicians be thinking about that? You know, on one hand, do we have to prepare for yet another source of chronic disease, or are these side effects uncommon? And how do we, in our practices, when we see patients with a history of COVID that seemingly have recovered, how do we think about odd things that seem to manifest themselves that just strike you as maybe not usual for this particular patient?
Well, you're hitting on something that is a work in progress and that it's evolving. We do know for absolutely certain that there is a post-COVID-19 syndrome, referred to sometimes as long COVID, chronic COVID, long haulers. It's got different names. I think we better get an appropriate, medically reasonable name for them soon. And what it is that variable percentages, and we're studying a number of cohorts now that the NIH is funding. And in fact, we have a program right here in Bethesda in which we're looking at a large cohort of post-COVID survivors. And we're seeing variable percentages, and anywhere from 25 to 35% or more, have lingering symptoms well beyond what you'd expect post any viral syndrome like influenza and others. It's fatigue, shortness of breath, muscle aches, dysautonomia, sleep disturbances, and what people refer to as brain fog, which is a non-medical way of describing a lack of ability to concentrate or to focus. So there's no doubt that that is going on. That can last anywhere from weeks to months. And it might even be longer. And the reason we don't know it's longer, because we've only been involved with this syndrome for about 10 months right now. So it could be even longer than that. The other thing we're seeing that's really quite curious and somewhat disturbing is that there have been a number of studies of people who have recovered virologically from either moderate disease or maybe severe disease, which required hospitalization. You didn't have to be hospitalized to get this. But when a bunch of cardiologists did MRI scans of the heart, they found that even in asymptomatic people, about 60% of them had indication of inflammation in the heart. Now, that could be of no ultimate clinical consequence, which would be fine, or it could, down the pike, lead to things like premature atherosclerotic cardiovascular disease, unexplained arrhythmias, cardiomyopathies. We don't know what it's going to mean. Hopefully it won't mean much. But the findings there are real. And that's one of the things we really want to keep an eye on.
What do we know now about the duration of immunity and the immune response after infection or after vaccination, or either one? And if, to the degree that we don't have complete knowledge, is it fair or not to transpose the length of immune response in other coronavirus family members or not? How do we think about that?
Yeah, well, another good question, but unfortunately an incomplete answer because we don't know the answer. Let me tell you what we do know. Well, let me tell you what we don't know first. We don't know the durability of antibody responses, which may be strictly correlated with protection or not, because it may be that the antibody level goes down, but your memory B cells and your T cells can also provide protection. But we don't know how long the serum antibody titers last, because we just started the vaccine trials. From what we know about the common cold coronavirus, the 4 viruses that are human coronaviruses that cause the repetitive common cold that we all experience every year, usually during the winter months, is that the duration of immunity to that is not lifetime immunity. It's measured in several months to a year or more. Unlike measles, which, as you know, is like it lasts forever with a 98% protection. We don't see that with common cold coronaviruses. What we don't know is that when someone gets sick with a systemic component of COVID-19, not just an upper airway, we don't know how long the antibody protection is going to last. It might actually be significantly longer due to the systemic nature of the infection. Because if you get just an upper airway infection, you're not eliciting the systemic immune response. It's mostly a local immune response. But when you get enough disease to put you in the hospital with acute respiratory distress syndrome or other manifestations, it could be that the immune response is going to last significantly longer under those circumstances.
You know, you've been immersed in this pandemic, as you have been in others. Are there observations related to what the physicians, whether the physician is in government or outside of government, what the physician's responsibilities and duties should be during a pandemic? Is it working pretty well, or do you see gaps?
No, I think it's working very well. What we all should be very proud of is what our physician population at the local level is doing. People in the towns, the counties, the cities who are in the hospitals, be they local hospitals or big city tertiary care centers, we're seeing our healthcare workers, our physicians, our nurses, and other healthcare providers really putting their lives and their safety at risk continually by taking care of individuals with a disease that has the potential to kill you and that is highly transmissible. So I think that this is a proud moment for the medical profession, and I think that we should be really aware of that.
How should physicians deal with patients that are hesitant to get vaccines when they come out? Do you have advice there?
Yeah, one thing is you shouldn't criticize them for that, because that's going to get you nowhere. I mean, if you have somebody that's an anti-vax approach, you don't want to ridicule them for being, but you want to try and explain to them what the reason is for getting vaccines and why the risk-benefit ratio, it weighs so heavily towards benefit. Some people, well, there's going to be a hardcore group of people who are not going to want to get vaccinated no matter what you tell them. But there's also a larger proportion and group of people who, because of misinformation, they shy away from getting vaccinated. And the easiest way is in a non-pejorative, instructive way to try and educate them to what the facts are concerning the vaccine. Go over the data with them and explain why it's important for them and their families to get vaccinated. I have found that to be very effective. I think when you start getting frustrated with people who don't want to be vaccinated and you have a tone of sort of blaming them for that's not going to win anybody over.
That's very helpful. Thank you. You know, we want to be respectful of your time, but I can't end without asking you something about your own service. You've served with 6 presidents, and when you do the calculation, it's astonishing that it's almost 15% of the totality of presidents of the United States. So you've seen. I'm sure that folks have had very different styles. The parties at different times have had very different styles. And you've had to adapt successfully and pivot, I'm sure, in many circumstances where the environment around you changes. What makes you effective across this long period of time? What kind of advice can you give physicians as leaders based on your own experience?
Well, I think you just need to stick purely to the science and evidence and data, and any recommendations, discussions, guidelines that you're involved with, opinions that you give, have to be based purely on the science. And just stay completely apolitical. Don't get involved in any of the political aspects, and just focus on what your job is as a scientist and as a physician. You do that, you'll be fine.
We've been focused on that. It's sometimes hard to do, but it is a really important piece of advice. I really want to thank you on behalf of the AMA and House of Delegates for this time. It's very insightful. We've all learned a lot. And we also, it would be wrong not to recognize our gratitude for your leadership at this time. Thank you very much, Dr. Fauci.
Thank you. It's a pleasure to be with you. Thank you for having me.
Thank you so much, Dr. Fauci and Dr. Madara. You know, if we were live right now, the applause would be resounding. That was an incredible, great, informative discussion, and we'll continue with that theme in the next portion of our program. Now I'd like to introduce our AMA President-elect from South Carolina, Dr. Jerry Harmon, who will moderate the next portion of our program. Dr. Harmon, take it away.
Thank you, Russ. Mr. Chairman, at the risk of sounding redundant, my sincere thanks goes out to our section members today. I truly look forward to the time when we might be able to safely gather in person in the future and perhaps leave our mask at home. For the next portion of our program today, we're going to have a panel discussion followed by Q&A. It's now my pleasure to introduce our panelists, an extraordinary group of AMA senior leaders who are experts in their respective fields. I want to note just how much your AMA, under the guidance of these and other senior managers, has worked tirelessly to solve the many problems and challenges we faced in this pandemic. Some of you might know that I spent decades in the military, and in that military career, we learned about applying the principles of war when faced with challenges such as changing tactics of large forces, or in this case, a large organization like the AMA, in a rapidly changing environment. This AMA team utilized what the military calls the principle of maneuver, the ability to be flexible in operations, to protect vulnerability, and to preserve free action. In this COVID pandemic, the AMA has acted with exceptional military-like precision. We're winning this battle because of their efforts. Each of our four speakers was going to give a brief summary of the work of their units within the AMA. You're going to hear today from Dr. Aletha Maybank, our Chief Equity Officer, Dr. Susan Skoshalak, our Chief Academic Officer, Mr. Todd Askew, our Senior Vice President for Advocacy, and Dr. Christine Sinsky, our Vice President of Professional Satisfaction, Practice Transformation Group. We ask you to please hold your questions until the Q&A portion. Let's begin today with Dr. Aletha Maybank. Welcome, Aletha.
Welcome. Thank you, Dr. Harmon, and a pleasure to be here just to speak a little bit about what has been going on with the Center for Health Equity, and I think the amazing work that we've been leading up from the AMA. We're very clear, most of us, that COVID-19 has really exposed centuries-long structural inequities and injustices that are experienced by those who are most marginalized in our society, especially those who are Black, Indigenous, and Latinx communities. And we know that the cases and hospitalizations and deaths have been more than double for those communities as those who have identified as white. And this unjust disease, the burden is actually exacerbated at the intersections of those who also identify as women, LGBTQ, those living in rural communities, and those who are differently abled. Corona exposed the lack of infrastructure, and at times will, to really better understand what was happening within these communities, and really represented the lack of data that was collected and shared so that we could be best responsive and redistribute resources, whether it's PPE, testing, and eventually vaccine, as was elevated in the previous conversation. So this last summer, we also learned that COVID at the intersection of the public murder of George Floyd and police brutality further confirmed our pervasive public health threat of racism. Fortunately, us as AMA, we did make the commitment for the creation of the Center for Health Equity 2 years ago, which really allowed us to be responsive in this very moment. And there was and still remains tremendous demand for all aspects and from all aspects of the healthcare and public health community for the AMA to be present in these key equity conversations that are happening across the country, and for us to really lend our voice and expertise and power to this national dialogue and to advocate for justice. And so over the last 9 to 10 months, the center has been focused on, centering equity. We've been surveying our marginalized physicians to really understand, their experience, hosting educational conversations with physicians via our Prioritizing Equity series, and just delivering a bunch of equity based content across our print, digital, and social media spaces, just to name a few. So I'm very thankful and proud of our AMA movement to date to advance equity, and really look forward to continue to build our strategy to advance AMA's goals over these coming years. Thank you.
Thank you, Dr. Maybank. Thank you. Now let's hear from Dr. Skosalak. Susan?
Thank you so much, Dr. Harmon, and welcome everyone. I appreciate your interest from my colleagues. I'd like to speak with you about addressing medical education during the time of COVID. And you understand that medical education has been disrupted at every level, from applying to medical schools and going through the admissions process, to understanding how to return to the clinical education environment safely, to applying for residency and fellowship now through a virtual process that we've never tried before. And even at the far end, when you finish residency and fellowship training, what is the criteria for eligibility now to sit for specialty boards? The AMA has advocated strongly for student and trainee safety. We've worked with external medical education associations to provide guidance in areas such as providing national standardized testing, clinical education sites, advocating for PPE for our students and trainees, and for clarity in the J-1 visa process for our international medical graduates. We have provided a series of medical education webinars on topics during the pandemic that have been of interest to faculty, students, and trainees. And most recently, we provided a series, for example, on leadership during crisis with faculty from military and business areas. And the recent one that we just completed, 4 sessions on addressing structural racism in UME and GME. We have an online community that you can find on our website with ongoing discussion. And at the Ed Hub, we've provided 13 modules on health system science online content that have been completed by more than 35,000 individuals. Right now, we're fielding a health system science student and resident impact challenge. We've received over 125 stories from our trainees across the nation on ways that they have provided leadership in addressing the COVID-19 pandemic. We'll be announcing the winner of that challenge winners soon, and we will publish a manuscript that includes all of these stories for you to read very soon. And during our recent virtual GME summit that we held last month, we held a GME Shark Tank for ideas on how to innovate across GME during this time of COVID, and selected 3 winners that now have innovation grants to develop those ideas. There are 2 topics that just remain top line for us that we continue to work deeply on. One is wellness of our students, residents, physicians, and all healthcare workers. And the other is addressing health equity. And we're working across the AMA to develop additional resources and inform people about these important topics. Going forward, the AMA will work with our students and residents and educators to adjust to this new normal of education as it continues to evolve during COVID and into the future. Thank you.
Thanks. Thanks so much, Susan. We appreciate it. Now I'd like to welcome Mr. Todd Askew, our Senior Vice President for Advocacy. Todd?
Thanks, Dr. Harmon. I appreciate it. Your advocacy team's been engaged in countless ways to support you and your practice and your patients during this difficult time. We've worked tirelessly to respond to the pandemic and the needs of physicians by pressing government officials at the highest level to address the need for things such as personal protective equipment, testing and testing supplies, clear guidance on testing, and countless other needs. And it's an ongoing work as new challenges continue to arise almost weekly, and we pivot quickly to meet those challenges. We also continue to work to promote the integrity of the scientific process. Vaccine hesitancy is a real and growing problem, even among healthcare providers. And the politicization of decisions that should have been left to science has led many to question the safety and efficacy of potential vaccines. We've been working closely with the FDA and the CDC and others to ensure that the decisions related to vaccine development, approval, distribution, and administration are based on science. And this work's going to be even more critical in the coming months as we all must work together to encourage the public to follow the science in defeating this virus. We also continue to work to support physicians and their patients so that their healthcare needs can be met during this difficult time. Part of this is working to increase access to and enrollment in quality, affordable healthcare coverage options to ensure that the millions of people who have lost healthcare coverage during this pandemic are able to access the healthcare they need. And also by providing continued financial support for physician practices that's necessary to help you keep your doors open and continue serving your patients. And that includes stopping payment cuts that are pending that make absolutely no sense at a critical time like this. And finally, we are continuing to work to create new opportunities to better meet the healthcare needs of your patients through expansion of telemedicine options, which may be one silver lining that comes out of this whole experience. These are just a few of the steps we're working on to help you fulfill your critical mission to meet the healthcare needs of the American people at this time. And we thank you for the privilege of doing it. Thank you, Dr. Harmon.
Thank you, Todd. We're certainly looking for all those silver linings that we can find, and I appreciate you being optimistic about that. Finally, let's close our introductions with Dr. Christine Sinsky. Welcome, Dr. Sinsky. Chris?
Yeah, thanks, Dr. Harmon. Pleasure to be here and pleasure to be with everyone. I think the most important thing I'd like to share is I believe as a nation, we have a bill coming due with respect to the accumulated stress of the pandemic on our physicians and other healthcare workers. Individuals can rise to the occasion once, but as a steady state, this level of stress that our physicians and nurses and other healthcare workers have endured is just unsustainable. And as you know, we know that burnout was already very high at baseline from some of the work we've been doing at the AMA over the last decade. And in fact, we're just weeks away from deploying our 4th national burnout survey. And I encourage all of you that receive this to complete it. It's really an important part of our development of the science around professional fulfillment and joy in medicine. But when COVID hit, our team very rapidly pivoted and also developed the ability to survey organizations and the individuals within those organizations. So we developed a Coping with COVID survey. We've now deployed that across 29 different states and over 75 different health systems. We have over 50,000 respondents now to that survey, and that includes physicians, nurses, and other clinical staff, but it also includes non-clinical staff, housekeeping, kitchen staff, for example. And I thought I'd share just a couple of the findings that we have in our preliminary analysis. We know that fear of exposure is high. Over half of the respondents are afraid for themselves or their family. Anxiety or depression that was brought on by COVID has impacted over a third. We found stress to be highest among our nursing assistants, housekeepers, and nurses, and that stress is also high among persons of color. We also found that this has workforce implications. 20% of our respondents intend to reduce their effort to part-time in the next year related to these stresses. And a third intend to leave their current practice within a 2-year period of time. So again, part of that bill coming due is what are the implications of this pandemic on the viability of our healthcare workforce. But there's some good news as well. There are some protective factors. Feeling valued by your organization or having a strong sense of purpose does protect from feelings of burnout and stress. So, and I'll stop there and look forward to our conversation in the Q&A.
Thank you, Chris. I appreciate it. I have a couple of questions that I want to submit and or have been submitted. The first one is to Dr. Skosilak as our Chief Academic Officer. Susan, should future medical education curricula possibly include more focus on public health?
Boy, that's a softball question, Dr. Harmon, because the answer is yes, yes, and more yes. You know, the AMA has been on record now for at least 7 years to say that there's a third science out there that has to be taught to all of our healthcare providers. It's not just basic and clinical science anymore. It's health system science. And within the large umbrella of health system science are the components of public health that include understanding how to work with populations and how to work with communities, how to value and address social determinants of health and structural racism that's occurring in our society and that's impeding the health equity that we seek for all of our citizens and populations. And ironically, in the second textbook that we just put out on health system science, the final chapter published before COVID-19 was a look into the future on how medical students and trainees could help improve the healthcare system. And the scenario that we used in the textbook was a worldwide pandemic and illustrated it with ways that our students and trainees could meaningfully contribute to the health of our citizens, our populations, our families, and our communities. So public health front and center. We need to bring public health and classic medicine back together in every way that we can do it educationally. I'm a strong advocate for. Thank you.
Thanks, Susan. I'm going to take notes that you're taking accountability for jinxing us with a pandemic in our text. Thanks a lot. This is the next question addresses something within your arena and Dr. Maybank's arena. Dr. Maybank, how can we, listening to the social determinants of health conversation that Dr. Skosilak just talked about, how can we improve diversity among our medical students and our faculty in medical education? Clearly, that's an extraordinary challenge, and all of us need to have an awareness of that and looking for solutions.
Absolutely. It's definitely an extraordinary challenge. However, I think it's also a very reachable opportunity for schools. And, you know, we have been thinking, and I've been in partnership with Susan on this, about what our AMA role is. But I'll first just mention a few things that those who are engaged in schools or at the school setting. I think it's really important at the institutional level, and the way that we've done here at the AMA is really to make a commitment that's explicit and visible to diversity at the institution, and to really express that it's important for all physicians in training, and not just the ones who are of color or LGBTQ, but for all physicians. And you can do this via making a diversity statement of sorts, but making sure there's also educational opportunities for folks to even understand what it means to be inclusive. I also think we need to encourage our admissions folks to consider more holistic review processes and really get rid of those notions that we are lowering our standards if we're increasing diversity, and really shed that narrative. But consider, the applicant's experiences and attributes and other aspects that bring strength, I think, to being a physician. I know for me that was definitely in consideration. I think at the root of it, we need to hire more Black, Latinx, and Indigenous faculty to be a part of these decision-making opportunities. I think looking at our data and looking at your data and then centering, the voices of those who are marginalized or excluded from your admission processes are also really important. You can engage your med students as well as people that you're serving in your communities to really influence the decisions that you're making. And then, Susan and I have been doing a lot of conversations with folks across the country. We've been going through this discovery phase to figure out, what is AMA's role in this movement and work around diversity in the medical space. And, in listening to people, there are folks that are successful in doing this. And so I think there's a tremendous opportunity for schools to research and look up the schools who have been highly successful in increasing their racial and ethnic diversity, especially the HBCUs, very successful in doing it. And there are some other med schools as well, and to reach out and learn what they're doing and figure out, what are some strategies that you could potentially adopt of success.
Thanks, Aletha. Thank you. Todd, ask you. We, in the prep for the session, we decided we'd stay away from most political questions, and we'd stay away from most NCAA football and academic challenges. But one of the things that is certainly going to be pervasive, and a question that's appropriate for you, is what opportunities might this next Congress afford us to increase access to health insurance coverage and perhaps expansion of telemedicine opportunities?
Well, thanks, Dr. Harmon. What is the next Congress? I mean, that's still a question right now that is not completely answered. Control of the Senate is unclear, but we are more likely than not to have divided government in the next Congress, and divided government unfortunately limits our options. There's been a great deal of support for supporting the Affordable Care Act, for encouraging states to expand Medicaid, the opportunities provided by the ACA, and to increase enrollment activities under ACA to bring more people. So many of the people that are uninsured now are eligible for either Medicaid or heavily subsidized coverage under the ACA. So there's no reason not to find those people and bring them into the system. I think, though, with very narrow margins either way, in Congress next year, more fundamental reform is going to be very difficult. It's going to be important to have that discussion, to see how far we can go, how far people are willing to go to find other opportunities to bring people into our healthcare system who are outside of it right now. And the big kind of unknown out there is what the Supreme Court does with the challenge to the Affordable Care Act. They'll be hearing that case next week. And sometime after that, portions or all, probably not all, but there is a possibility that portions of that act could be invalidated. And we don't think it's likely, but it's still a possibility. And that will create a whole new opportunity, a new imperative to have this discussion that we seem to have every decade about the need to fundamentally take a new look at how our healthcare system is designed. And so it will be difficult to make progress this year, but the discussions, I think, are just too important not to have. And so I think we all look forward to engaging in that process.
Thanks, Todd. Very comprehensive answers in an undefined environment. So thank you. Dr. Sinsky, I heard we talked about the AMA's Coping with COVID survey. We had some discussion about it in your introduction. How can we, practicing doctors, learn more about the AMA's Coping with COVID survey? And one of the things that I'm going to throw in there is a two-for question is, in my practice and in my world, I see a lot of challenges in telehealth and telemedicine. I think that's going to be part of our post-COVID world. I think it's both an opportunity and a threat somewhat to physician practices now. So kind of a bipartite question, but how can we learn more about the Coping with COVID survey, and how do you think physicians are going to be able to adapt to telemedicine in a post-COVID world?
Perfect. Happy to have a two first. So thanks. easy on the first one. Anyone who wants to learn about the Coping with COVID survey, which is something that we do at no cost for practices, it's part of our mission work at the AMA, you can go to clinician.health. And when you go to clinician.health, you don't need to put in www or anything else, just clinician.health. There's an FAQ, you can register for the survey. One of our staff, we have a tremendous staff working on this, and one of them can answer questions by phone. And we meet with organizations that are surveying both before and after, because we can add a few custom questions. And then to that next piece, and we are actually planning then some academic publications to come out of this. We've already submitted one academic publication. We have another one in the pipeline from our database from the Coping with COVID survey. But then pivoting to telehealth, you know, I was thinking about this morning. We all now are so comfortable with Zoom meetings. We've learned the value of them, and we know the pros and cons. It's really great. It's convenient. It's what we have to do now, but we've also missed something in terms of the personal relationship. And I think patients and physicians have learned the value of telemedicine visits, and that they are feasible, that they can be effective, that there's value there, but that there are pros and cons. And so I think that telemedicine will continue post-COVID to be an important delivery model, a delivery mechanism, but I don't think it will be the exclusive delivery mechanism. And what some of the practices are finding as they let patients make the choice of having an in-person visit or a telemedicine visit, that's actually the way to be patient-centered. And when patients are making the choice, the early data suggests that about 80% will choose an in-person visit and about 20% will choose a telemedicine visit. We don't yet know what the optimal is, but I do think we know it's feasible, and that by and large, we should allow patients to choose the platform.
Great, Christine. Thank you. Susan, I have another question here. How is the AMA, and this is practical right now because we're in the midst of applying for the match, as it were, in our medical student graduates. How is the AMA working to help students who are working to select and actively engaged in selecting residencies virtually during the COVID pandemic? What AMA resources might be available to them?
You know, our heart really goes out to our students and to our residency programs. This is a new world. We've not done this before. We've taken away the ability for our students during their fourth year, for most of them, to do any kind of audition interviews. And so they don't have the confidence that they're seeing the programs in the details that they wish. They're having to apply virtually, so they're not being able in many times and ways to get on site and look at the resident colleagues that they would be matching with in the lists that they're generating for the match. The program directors are challenged in understanding how they can best assess the applicants holistically through this virtual environment. So it's a tough time right now. And people are worried that because it's a virtual application process, the numbers may be even higher than what we've experienced over recent years. And we all know those numbers have been causing real problems during the match process in terms of just handling the volume. So we're going to learn a lot, and we're trying to support our colleagues through this process in every way possible. Our webinar topics have included how to do virtual interviews, how to be ready for and what to look for in terms of ways that you can find out more about programs. Our Frida product, which is our AMA residency and fellowship directory, which is used by tens of thousands of students and international graduates, has been upgraded with major improvements, and it has included the ability for residency programs to put video on site so that they can say more about what's important about their program and really help the students kind of sort through the things that they're looking for. Of course, residency programs are doing virtual visits with the resident colleagues and other things. But when you look down the line, Dr. Harmon, I think we're going to learn a couple of things that may be that there are some benefits from doing this process virtually. Certainly from an economic standpoint, it's not as expensive, and our students are really burdened by the debt that they have from medical education. It may be that we're able to take some of the numbers and the usual rankings that seem to always benefit that top 10 or 15% and put those aside and really look for ways that we can really holistically select the right student for the right program that meets their needs. And then finally, I really have to give a shout out to our AMA's Reimagining Residency grant program. We've got 11 partners that have been working with us for a year now, and they're trying out new methods to really help with that handoff from UME to GME. One of the programs that we're supporting is in partnership with the OBGYN community, APGO and other leaders that are experimenting with the possibility of an early decision process for a component of the match. And a second area that we're working with NYU School of Medicine and their affiliated hospital programs is a structured handoff that allows a more complete evaluation when the match occurs of where gaps might have occurred in education. That's always true. We all come as incomplete when we go into residency. We're not fully Croissant physicians yet. But during this time of COVID, where some people have had less experience clinically because of the pandemic shutdowns, it's going to be very important that residency programs know where their applicants, now their new interns, are in terms of what is their competencies that they've achieved and what are the gaps that the residency really needs to help them with to get up to speed. So I've given you a lot of details on the importance of this year, what we learn, and how AMA can continue to support informed, scientific, and well-reasoned processes going forward that we'll learn from this year.
Thanks, Susan. That's very informative and very thorough. Thank you. Looking at the number of probably medical students and young physicians and residents and fellows on the call, I'm going to put the next question to Todd Askew and ask him one of the $64,000 questions. Todd, do you foresee improved government funding sources for medical education in the future, especially graduate medical education? We continue to have a mismatch between the number of graduating medical students and the opportunities for career continuation in the graduate medical education arena. Any foreseeable improvement in the future from an advocacy standpoint, Todd?
Sure, Dr. Harmon. It's obviously a critical need, and I think there is some opportunity in some of the programs that exist through the Public Health Service Act to promote a diversity in medical education. Programs like the one you participate in, the Teaching Health Center GME, I think programs like that have good futures. The bigger challenge, of course, is funding for the general line of Medicare funding for GME and IME, which has been kind of stuck, with the cap that we have been fighting against for more than a decade now. And given the fiscal challenges we face, literally trillions of dollars in new debt being taken on, and what I anticipate will be calls for, spending limits and not expansion. I think it's going to be an uphill fight. It's one we're going to be engaged in. It's one that has a clear and demonstrated and critical need, and we will certainly continue to push that rock up the hill. But it's going to be a real fight in the short term, a real difficult task in the short term. Much of what we've been doing in the last few years has been fighting off proposals to cut, to diminish, and to reallocate some of that funding. And when you're fighting a defensive war, it's sometimes it's good to go on the offense, but you can't take your eye off that ball where there's efforts to reduce the funding. So we'll keep up the fight, but it's gonna be a tough one.
Thanks, Todd. Aletha, I'm going to put the next question to you. We've heard discussion about the need to improve education among physicians in areas such as diversity and social determinants of health and public health outcomes, and the need to think a little bit outside the COVID pandemic and the scientific box. Just what health equity resources does the AMA have available right now for physicians and medical student and residents who want to learn more about social determinants of health and health equity issues? Can you give us some ideas what's available right now?
Yeah, sure. Thanks for that question, Dr. Harmon. During this time, and again, we're what now I think the center is about 1.5 years old. And we've been, to some level making the road as we walk here. I would say maybe run during the COVID time. But really what we've noticed, as I've mentioned earlier, and part of the reason for running is the tremendous demand, not only that's required, by what we're seeing in society with the pandemic, but also racism and the elevation of structural racism, but also the great desire amongst our own membership and many folks on this call who have been reaching out to say, what do you have, available for us? We want to know, how do you embed equity? We want to know how you do it in terms of emergency response. We want to inform ourselves, but we don't know where to get the resources. And so we've been working very closely with other folks across the management team, especially MMX and EC. I really think about, the strong partnerships that we've had to get some of this out. But we launched the Health Equity Resource Center on our website, I would say now probably about 4 months ago. And that has evolved tremendously. We've had lots of visits, and we've now provided an additional resource within that site of what other people are doing across the country. There was a reach out to the center, because we are a national, to say, we want to learn, how do you center racial equity? How do you do racial justice at our healthcare institution? Who's doing it and who can we learn from? So now we have a portal up that really highlights, I think there are about 8 or 10 examples across the country of folks who are doing that work. So we want to make the resources that we provide more and more meaningful and responsive to what the actual needs and demands are. We are getting ready to launch our Health Equity Education Center on the EdHub, and really excited about that. That's one of the big demands. How can we get credit, for learning about structural racism or structural competency or the social determinants of health? So now we've pulled together and partnered with several external entities to really have one central place where people can go on the EdHub to get health equity education and information. And we've been, I think important to this work, during the COVID time, but even before and after, is really still working to transform our culture, at AMA. And I think we're providing examples on how to do this with our management team. We're still hosting our equity trainings for our teams and sharing these examples with folks like on the Federation. And we're starting to set up meetings and working with the advocacy team to be in more communication with the Federation around how do we work to shift culture to support advancing equity. And I would say, lastly, one of my really the efforts that I'm really proud of and grateful for is the release of our Latinx COVID report, which really is speaking to, it's a qualitative report, speaking to leaders across the country to better understand and explain what is happening in the Latinx community. But what's really exciting about that is that through this process, and with the partnership again of MMX and EC, AMA has launched their first bilingual campaign in Spanish and English to really improve COVID engagement efforts with the Latinx community and Latinx physicians. So it's our first bilingual campaign, and I think that's tremendous. And also part of that effort is being inclusive of AMA members who have now graciously accepted to become Spanish-speaking spokespersons for our national organization. So I think, during this time, we have really worked very hard to make sure that we are pushing ourselves to be responsive to what is actually needed to help advance equity for ourselves as the AMA, but really for the field of medicine overall.
Aletha, thanks. That was a wonderful answer, and I took a lot of notes, and I'm sure other people did too. Dr. Sinsky, Christine, I'm going to give you the final question. We're running a little short of time. I heard a discussion about the EdHub and some resources there were available for health equity issues from Aletha. Does What resources does the AMA have that could make available to help physicians dealing just day-to-day stresses of COVID? You know, we're running into financial issues. We're still, most of our surveys show physicians are still struggling financially, operationally, and in a world of uncertainty in COVID recovery. What resources does AMA have that you might offer?
Right. So that's such an important question. And as you alluded to, a recent AMA study showed that on average, practice revenue has dropped by over a third for our physician practices. 1 out of 6 practices has lost over half of their revenue. So this is a really important issue. So one resource is we do have a guide to opening your practice post-COVID. So that's something to look for. We have over 60 online toolkits that are practical, actionable, one-stop resources to learn how to do something. One of the modules that we have, one of the toolkits, is caring for the healthcare worker during crisis. We wrote that with the chief wellness officers of Mount Sinai in New York and Stanford, with very practical ideas about how do you address the healthcare workers' needs during this time. We have other resources within that Steps Forward set of resources on how to practice more effectively, more efficiently, so that you do have a stronger revenue position. So the number of resources that we have is just terrific. And I would encourage everyone to go to stepsforward.org and take a look at what we have that will help with improving practice efficiency, improving organizational culture, improving leadership, and improving our ability to help our workforce during this pandemic.
Chris, thank you. I took notes as fast as I could. I'm glad we recorded this. We can go back and look at it. I want to let everybody know how much I appreciate all of our panelists taking the time and our attendees to take part of their Saturday morning to be part of the AMA solution set. What we heard from our panelists, Letha Maybank, Susan Skocilak, Todd Askew, and Chris Sinsky, was an offering of that silver lining going forward. We've been dealt the pandemic, not just because of our textbook, but we were going to be dealt that pandemic, and we're overcoming. We're doing what the AMA does best, what physicians have learned to do for centuries, is to adapt and overcome and succeed. So we're doing that very well. Russ, I'd like to turn it back over to you for closure, Mr. Chairman.
Well, thank you very much, Jerry, and thank all of you as excellent panelists. I'm sure we've learned a lot about what the AMA is doing today. As we move towards the conclusion of today's program, and as you move into your individual groups and begin the important work of your sections, please remember that it's our dedication to patients, our adherence to science over politics, and our diversity and inclusiveness that have led to our great strength as physicians and as an association. And through that strength, we carry out the important work of the AMA to sustain practice viability, remove the obstacles that are interfering with our ability to deliver the very best care to our patients, to drive the future of medicine through improved training, education, and innovation, and to lead the charge to prevent chronic disease and to confront public health crises just like the one that we now face. So I thank you for your commitment to this work, for your excitement, your energy, and I hope you will all have a great meeting. Thank you so much.